So good evening, dear all Facebook Pure Urology viewers. We have today our special speaker, Dr. Vineet Gauhar sir. We are fortunate to have Dr. Vineet sir as the speaker here today. And the topic is on scientific approach to ERBT, en bloc resection of bladder tumor. So I would like to introduce Dr. Vineet Gauhar sir. He is the principal resident physician, urology, NG Teng Fong General Hospital, clinical lecturer and physician faculty, NUS School of Medicine and NUHS Fellowship Chair. He is the board member, Research and Technology, AUSET, Endourology subsection of UAA. He is the member, EAU Guidelines Dissemination Committee. He is the associate member, Research Group, European section of Endourology. He is the academic consultant, Asian Institute of Nephrology and Urology, scientific board member of Endourology Academy, Kidney Stone Academy. He is the principal, as the principal investigator, he has pioneered around 20 real-world multi-center studies with more than 200 peer-review publications. And the key recent surgical contributions in endourology are, he devised the modified ergonomic lithotripsy technique for performing RARS. He coined and introduced and developed the concept of DIS, direct in-scope suction in flexible ureteroscopy. He has coined, introduced, and developed the concept of FANS, flexible and navigable suction axis sheath for flexible ureteroscopy. He has co-invented the GLITZ system for DIS concept in flexible ureteroscopy. The awards, there are several awards he has received, and the prominent ones are Silver Ambassador Award, NTFGH, and Identify Study Best International Research Study Award, the award by Asian Journal of Andrology in August 2020 for top 10 research papers published, CAU Best Research Award for Distinction, and prize paper presentation at Confederation Americana de Urologia No, Predictors of Mortality and Emergency Nephrectomy in Patients with Emphysematous Pyelonephritis, a global multi-center study. At Montreal, he was awarded the Bantock Best Paper Award, SIU, for DIS device solutions, and at Singapore, Service Champ in Urology Award. So the list continues, and we are not able to finish sir's CV in a given time. So I'm handing over the presentation over to Dr. Vineet Gauhar, sir. And we are all waiting to hear from you, sir. Thank you.
A very good evening to all the viewers, or good morning wherever you are from. It's 7:30 p.m. for me, so good evening from Singapore. First of all, a very warm thank you and regards to Saundarya and Chandramohan to give me the opportunity to come on to Pure Urology. The distinguished awards and rewards are never one person's achievements. They're always a collaborative effort. Somebody gets them. I was just lucky to get that. So thank you to everybody for that. We'll come to my topic and I'll start sharing my screen. Okay, so as we always ask, are you able to see my screen?
Yes, sir.
Okay.
You're audible and the slides are visible.
Thank you, Saundarya. So I'm taking on a topic which is generally I'm not very well known for, because I'm well known for stones, and then after that a little bit of BPH work as well. But this is a favorite topic of mine, and as we build through this, I'll explain to you where my interest comes. And I owe a big thanks to, most of you will know, Jeremy Teo, for introducing me to this concept. To me, when I was introduced to this concept, the first thing that I needed to understand, and I always try to do that, is you have to have a scientific approach towards anything. And en-bloc resection also requires that. So the essence of my presentation as we go through, and these are some of my disclosures, we will be talking about what is it that is so different about ERBT. I'm sure a lot of you do it. Most importantly, why have we moved from resection of the bladder tumor the transurethral way using the loop to an endoscopic resection of the bladder tumor en bloc? This is because we know, and this is not something which is new, but what's interesting when I was looking at the literature is that in 2035, and these are some statistics which we picked up from different papers, so I'm not quoting the papers here, but they are actual statistics. Imagine we are going to have 175,000 new cases per year in another 10 years' time. The second, I mean, that's like 41% worldwide increase in this tumor in 5 years. And with the shortage of BCG that we talk about, we really need to do something at the first step that it comes to us, where we make sure that we are able to remove the entire tumor, ensure that the patients do not have a recurrence. Perhaps we can manage it if it is not yet a muscle invasive bladder tumor conservatively, because this is really, really impacting on their lifetime. As you know, this tumor requires a lifetime surveillance sometimes. And the world's already spending enough money on this cancer, and we don't want to be spending 41% more of our budgets every year. So looking at this, the two main problems with TURBT, as you know, typically when we resect, of course, there is a problem of removing the tumor fully because there's a bit of scarring that happens, or there is a bit of charring that happens. And we're always wondering whether we've left behind residual disease. When we send the tumors to the pathologist, very often the architecture is quite destroyed because of the energy that we used. If it's a piecemeal resection, we don't get the intact architecture, and we are always wondering whether we have missed out detrusor muscle. We sometimes are unable to get detrusor muscle. And then, of course, we typically don't do bladder washes so religiously, and there's a possibility of tumor reimplantation. So recurrence and tumor understaging are the two main essential problems of TURBT, and this is irrespective of how much of experience you have. We won't go into this discussion because this itself is a presentation. But taking on from there, we have to understand, if you look at all the recurrence mechanisms of non-muscle vessel bladder cancer, the single most important one is that you missed it, first of all, that's undetected. Then there is a local residual disease. That means you cut it, but you left behind. Or there is reimplantation in the field, which you have been doing, because we know this is a field chain disease. We may miss the concept of CIS. And that is actually the reason why most of the bladder cancers, which are non-muscle invasive, come back. So if you have to tackle, and if you want to change the way you do something, you have to wonder whether whatever new surgery, which is not very, very new, but still, if you're doing it a new way, is it the way forward? And is it the most important? So this was the most important question that we will try to answer as we go through this presentation. So some of you may have seen this very famous slide, but you know, this procedure is not new. It was actually in the 1980s. And they actually, even then, without a level 1 evidence, but they were able to say, you can get a full specimen and you can avoid the chance of tumor reimplantation. But for some reason, we only started to do resection of the bladder tumor. Perhaps we didn't know how to do it, and perhaps we were not so well trained, and TURBT just became the standard, just like TURP around this time. So if this was there for so long, why is it of interest now? Because you have to have somebody, and I take this opportunity to thank Jeremy, because he has singular interest in this procedure and singular interest in this field. And he's been pushing everybody and introducing a lot of people to this. Some of the slides and the videos are actually courtesy him. I know he has also come on Pure, so perhaps there's some repetition, but I'll present my point of view from what I think is a scientific basis. To me, singly put, yes, recurrence and tumor understaging is my main problem. So if you look at what must unblock be able to do, this is a very, very nice paper that came out in 2019. And this was what convinced me that even I should move towards unblock. So not so long ago, it's only 2019 that I shifted. At that point, if you look at this, it says the surgical strategy should be defining all the including extent. That means we should be able to include the entire extent of the bladder. We should be able to control the specimen and send it as a whole for an oncological outcome. That means it should be an oncological surgery. And the endpoints should be similar. I'll just summarize this. The endpoint should be similar to what we were doing with resection of the bladder tumor. However, we should make sure that there is no understaging. So that's when we think the prognostic role of ERBT may be also useful. So there was a collaboration consensus statement, which wanted to understand what are the important parameters that we should do when we do a ERBT. The procedure may seem very simple, but if you don't know why you're doing something, you perhaps are not thinking of what can the systematic outcome be, because patients will ask you, what is the possibility of this, and what is the possibility of recurrence, etc. So to generate that, it was important to understand that there were so many parameters, because if you have 103 statements to discuss, obviously you're missing out many things which are not there in literature. But what they could come down to, the 2 or 3 more important one was ERBT should be considered for non-muscle invasive bladder cancer. This is at that point of time in 2020. It should be feasible even for tumors larger than 3 centimeters, but they do not have enough proof, but it should be feasible. It should also be able to take all the tumors which are there in the bladder, and it should be possible to do this even in any location. Whether you do it in the dome or whether you do it in the base, you should be able to take it. You must have at least 5 millimeter of margin around the base of the tumor, because that's the possible way that you are taking the entire tumor. And perhaps if you go in with the muscle, you'll prevent recurrence. So I think the key points this laid out was the basis of doing any further studies. So people had to decide on a study and consider how to plan a study based on those statements that came out. So now you have some proof of concept. What should ERBT do better than TURBT? So this was when they decided to do the first study. And is it possible to even implement it in your setting? Because maybe in Hong Kong, which is why I put this over here, they were able to do an excellent setting. But if you can't replicate it, you cannot reproduce it, and other people can't do it, then the surgery is your surgery and not everybody's surgery. And again, it should be possible to do this in all setups. I should not have an exclusive setup where, okay, I can do it, because TURBT can be done in your hospital and my hospital, or even by a trainee or even by an expert. So that's the whole idea. Well, they were able to replicate this study very well. It was a nice multi-center study. And interestingly, they were able to find a success in 84% up to 3 centimeters. So again, that question about 3 centimeters, the success rate was not so good. But what was important was, if you look at it, it didn't matter whether the tumor was multifocal. And if you just take multifocality and tumor size, that was probably the limitation. But otherwise, you can get a very good technical success. And when we say technical success, remember, we spoke about all the points that ERBT is supposed to do. You were able to get a 5 millimeter margin. You were able to get the entire tumor. You're able to get detrusor muscle. You're able to go wide, and you're able to remove the entire tumor. And you're quite sure that the architecture of the tumor is maintained. So this was really good, because first time world over, people were doing this, and they were confident of doing this in 3 centimeters without any major complications. And they could do it for all sites, which is also good. Imagine if your pathologist gets a specimen like this, they're going to be really happy, because the architecture is well maintained. Even to you and me, who are not pathologists, we can look at it and say, yes, this is definitely good preserved histology. So the en-bloc resection specimen actually gives you a very good detailed outline. You can actually see some detrusor muscle elements, so the depth of tumor can be really well ascertained. And a proper staging and complete tumor resection is actually achievable. And that was this main study which was able to show. Once that came out, people then started looking, okay, if we look at this surgery from a TNM perspective for staging, are there any key steps that we have to look at it? Now, this is what we were doing, or what some of us are still doing in resection of the bladder tumor. We take off the tumor, we then go down to the detrusor muscle, and we take a cold cup biopsy sometimes, because we want the histology over there. So this is the typical way, and you must have seen sometimes you need to bend the loop forward, bend the loop back. So nothing really has changed, because you're actually doing the same thing. But what has changed is the way you're doing this surgery. In this surgery, typically, if you have a very simple, small lateral wall tumor, even if you're doing monopolar or bipolar current, with the bladder resection, what we were doing typically, we were scared that we can have a very good operative jerk. Somehow, if you're doing it in ERBT, this jerk is not much, because you're actually just going dot-wise circumferentially. We'll fast forward some videos for saving time. And you can actually outline the entire tumor. You can see it's 5 millimeters around. Now, this is a surgery which was being done by a very junior, very novice person very early on. But this is exactly how the stages are, where you keep the loop perpendicular to the bladder mucosa, and short bursts of energy. They actually coagulate the vessels. So you can see it is very, very clear. What you get over there is definitely some detrusor muscle is identified. And by an antegrade and a retrograde movement, in a very hemostatic way, you can actually get the whole specimen on a stalk, which is perfect because this specimen is going to come out. Now, that specimen and an easy specimen, if you have something like this, the same philosophy, same principles apply. You have to manage your loop in a very circumferential and tangential way. And you can actually go in exactly the same way and get the whole specimen. And this is about 3 centimeters. But this is the reason we are showing this video is because this is teachable. This is very easily teachable to anybody who's doing it, that this is the way to do it. In your own practice, when you do this, you will yourself observe that because there is no lateral dissemination of current, there is no continuous current, you won't have obturator jerks. So actually, you can do it under spinal anesthesia as well. Now, of course, if there is evidence that it is muscle invasive, and if you're going too deep, perhaps maybe you may have some, but muscle invasive tumors, if they are visible, we may not be wanting to do a ERBT. So with this, we'll go to the next thing, which is, okay, why can we do this even the normal way where we have a NBI so that you can see the tumor better? Now, if you look at this here, it's obvious that there is something there, but we can't see very clearly. So what do? We change to NBI, which is basically in a white light, and then you go to the narrow beam imaging. Now you can see there is definitely CIS and layers of CIS all over. So this is a patient who's already had BCG and now is BCG intolerant. So either you can resect as we did, but you're going to get a whole carpet, or we can attempt to even do an NBI. The same principle, you actually can remove a whole carpet is what we're trying to show over here. So you can go really wide and you can actually take off a whole carpet of tissue. You will find that your patients are much more tolerant because you're not removing too much of the glycosaminoglycan layer. Already that will be pretty much destroyed with the BCG and the tumor. But the patients tolerate even such a wide margin of resection, as you can see over here, much better than a conventional TURBT. And this eventually even came out as high-grade non-muscle invasive CIS, but the margins were clear. So the patient was disease-free without further BCG at 3 years. What it means to say is the same principles, but a better surgery. So if you have the same principles and the better surgery, why not? And interestingly, a friend of mine in Japan, well, it's his team and a couple of other people, they asked the pathologist, and pathologists also find an ERBT specimen to be much, much better. Interestingly, they said it was also easy for them to be able to give us a much better analysis of the T1 substaging. So for pathologists and for surgeons alike, seems to be that ERBT is scientifically a better procedure to do. So obviously, then the big question that comes up is you have to do a randomized non-inferiority trial. It's reproducible, yes. It is doable, yes. But unless you do a non-inferiority trial versus the standard of procedure, can this be a possibility? So this was the first European study which looked at all those factors which were discussed in the statements. And then they did a very interesting study. And at the same time, there was also another study which is called the En bloc study team, which wanted to also look at the similar concepts, whether TURBT and ERBT is a better procedure. And typically in Asia too, there was the EV STAR study which was going on. And all the studies were able to utilize the same methodology of comparing ERBT with standard resection, which is TURBT. And the outcomes of all these procedures, and we'll just discuss one of them, which was the Asian one, which came up, which actually showed, and if you look at this red line versus the blue graph, clearly ERBT is a much better procedure when it comes to recurrence rates. That's the primary outcome. Progression rates are also better with the ERBT group. There was no progression actually. And other outcomes such as the sample of the detrusor which is available, the patient's hospital stay was shorter. There was no upstaging. That means you were not downstage. I mean, you are getting the correct histology, and the 30-day complications were very similar. So once you have such a proof of concept scientifically showing that this procedure gives you a better outcome for non-muscle invasive bladder tumor, then we need to change the way we do the surgery. And perhaps because it is so important that without BCG, those patients, the recurrence was lesser. And even if you look at patients on BCG, the recurrence was lesser. This procedure seems to be, so that means the first time, if you do the procedure well, your patients are going to benefit, and you may be saving a lot of patients receiving BCG, or you may be saving a lot of necessity to go back into OT. So if you can do that, you may be thinking, if I get a tumor like this, is it possible? So when we had a tumor like this, somebody said, why don't you try en bloc resection? So we attempted en bloc resection. Obviously, it was not going to be an easy procedure. We resected it for 1 hour, but it's impossible to really remove it in one piece. So you can actually make the tumor half and then take out half the tumor at the base. So multiple pieces of removing the tumor still gives you a good histology. And the second leg negative was negative. So even if you get a tumor like this, don't hesitate to consider doing an en bloc resection. And you do have evidence to show you how to do this, where you actually debulk the tumor on top first. When you see a tumor, the margin has to be outlined. B means debulk the tumor. C means you remove whatever is most of the tumor. And the last part, go down and pick up the base in the most systematic way. And these are some of the tumors that you see over here, where you're still using a loop in an en bloc way. And it can be look a bit scary at the beginning. But as you gain experience, the same oncological principles, if you follow, you actually find them to be much more hemostatic when you're doing the surgery. So again, short outbursts. And if you look at all those, I'm just going to save time, they were the same kind of resections. If you look at this, now this is some of you may know Dr. Salim. So very interestingly now, he's actually vaporized some of the superficial specimen. He's then resected most of the tumor, which he could. He's got the base separately, and he's actually labeled it and sent it to the pathologist. So you know which is the bladder side, you know which is the tumor side, and you also have the muscle. And that's how typically you can debulk and send a very big tumor. And that's typically how the pathologist would want you to send the specimen as well. So after the first one, then they had to do modified tumor where they had more confidence. Can it be done for a 3 centimeter tumor? Now you have to look at this in a very, very oncological way, because you must have a complete resection. In non-muscle invasive bladder cancer, that is not, you cannot compromise on that. And you must have proper staging. So when this study took place, which is one of the biggest studies, they actually had now MRI, because you had VIRADs. So you're actually able to look at it in a better way. Now, with evidence of doing a resection and concrete evidence of both visualization and an MRI proof that you can get a T0 resection, even with a 3 centimeter tumor, whether 3 centimeter in the vertical or 3 centimeter in the horizontal direction, you're actually able to get an R0 resection, which is amazing. Not only even in the lateral tumors, but even in the tumors in the dome. And even in the tumors, the patient has a T0 resection. So this gives you the confidence that, and this is first level evidence, which tells you that you can get up to 91%. Once you have enough experience, you can get a proper ERBT specimen. So modified en bloc is different from en bloc. Why? Because I just told you, you debulk the tumor and then you remove it in piecemeal. We still don't have any device to take out the entire tumor in one, the whole thing comes out in one nice, beautiful specimen. When they are big, they have to be in smaller specimens. But you don't cause too much of tumor spillage because you're only resecting just the superficial part or vaporizing the superficial part, debulking the tumor, and actually removing what you normally remove for a T1 disease. So the question that came in and where I came in is when lasers came into this. And Jeremy still was talking mainly about doing it with monopolar and then eventually bipolar. Now, when we have so many lasers, we might as well shift to using lasers. And that's when I came in, because we have laser energy. And this is something which, it doesn't matter which kind of a laser you use. I'm just going to show you 3 different specimen samples here. The advantage with the laser is the settings just vary depending upon the type of laser you use. And now there is also a thulium YAG laser, which is even more, pulse thulium YAG, which is even more hemostatic. With the laser, you can actually go very fast around a very large base of the tumor. So 3 centimeters sometimes is not too much of a challenge with a laser. And you don't need any special device to push it, because just the laser vapor bubble itself, as you do this, it will push the tumor away. And you can see over here, if you do it very methodically, you get a beautiful detussa sample and is extremely hemostatic. And if you do still want to, you can actually just cauterize the edges. Patients' response to this, and this is something which we are studying when you take conventional ERBT versus laser ERBT, we find that the patients are having lesser bladder symptoms, lesser bladder spasms. The need for a post-op catheterization time is much lesser. Lesser patients are actually needing even painkillers. So there is definitely a good thing in this. Laser has actually made operating on tumors close to the ureteric orifices and certain challenging places much easier. So I do think that with level 1 evidence that ERBT is good and level 1 evidence that it can be done even in bigger tumors, there is evidence that lasers may be the better energy source. Which laser? You can do it with all lasers. That's the whole point over here. It doesn't matter which laser you have in your clinic, you can do it. And 1 joule, 10 hertz is achievable by almost every lasers, right? So you don't need the very fancy lasers, at least for ERBT. So with that in mind, it was only natural that somebody will start thinking of developing specialized instruments. This is friends who are working on this. And they are now looking at how do you make it the easiest way in which you can use even tumors which are in the difficult areas to reach, such as diverticulum, dome tumors. And these are just some specialized modified resectoscope. They're actually called the resectoscope meant for ERBT. It's kind of a entire rotating head, and you can see instruments inside. They're magnified here. They're very small. What this allows you is to sort of grasp the tumor, and then you can pull it down, and you can actually use the laser to remove. So this is really good for, typically you ask sometimes your assistant to push down the Creed's maneuver. This is something which can do it in one instrument itself. And it's a very good, because it also drains out the fluid at the same time. Of course, this was in a pig model and is now being studied in the human model. So ERBT has come a long way from 1980. The future, I think, is currently on looking at the real world data and more RCTs to define this. To me, if I have to look at it, there's a surgical perspective in which the ERBT is better, and then there's an oncological perspective. Practically, I feel that you can get a complete tumor removal. You will almost certainly get a detussa muscle. It's very rare that you missed it, because you're not scared to go deeper, because the hemostasis is better and you're unlikely to perforate the bladder. And you will also have no obturator jerks in practically when you're using it. From an oncological perspective, which is more important, as we showed before, relook is much better, resection is more complete, a single dose of mitomycin instillation can still be done for those who believe in it, and you can actually confirm it with an MRI the next day itself. So that is something which really is really good, and I think that's where level 1 evidence is pointing. Of course, evidence will continue. There's also robotic instruments which are coming out to further define this procedure. This is kind of, I don't know how far it will be good, but then Virtuoso Surgical is a Vicarial Surgical is really developing this, where you can see with just a simple laser, the same concept. You can hold on to the tumor, but these are the instruments which are working inside. These little things which go through your cystoscope or through a 10mm laparoscope. So this is something which we don't know, but it is really good, because if you can do this to a patient, expense is one question, but oncologically, will this benefit the patient? It's yet to be seen. But innovation continues to happen in all fields. I just took this slide from Jeremy because it says what we have to say. If I'm always concerned with a certain procedure that I don't know whether, because of the charting, I don't know whether I removed all the tumor, there is a high possibility of recurrence in 10 years' time. And if I was not able to change TURBT in spite of all the other treatment options, if I'm still considering post-operative mitomycin and I'm looking at BCG problems and a second look, then I think we really have to change the way we are doing the surgery, because we are not removing the tumor as a whole. And I think that's why ERBT is really most important. Whether this will change this entire thing, that means whether it will change the need, absolute necessity for recurrence will be lesser, relook itself can come down, will take off the need for surveillance, flexible cystoscopy. whether patients may not need intravesical BCG maintenance. These are something which we yet have to study. And that's why, since we have to study all these and we need many more questions, we have what is called as the Global ERBT Registry. It's interesting because there are, I think, 40 to 50 countries which have joined, and more countries are participating. If you are keen, you can contact Jeremy directly, or you can contact me. And we hope to be able to give you better answers in the near future. So thank you very much for that.
So thank you, sir, for the clear elucidation of all the ambiguities in ERBT and any person's skepticism and all the fears of switching over from the conventional TURBT to ERBT. So, and you've proved the scientific point beyond doubt that ERBT has its place. So I have some doubts. So can we start the discussion, sir?
Yeah, please go ahead.
So, sir, for large tumors around 7 to 8 centimeters solid tumors, if you start resecting or debulking them with a monopolar, do you think the chances of implantation of the cells will be high? And in such cases where the base is going to be quite broad, so do you think it is really possible? And in case if the such a broad base you're able to resect it en bloc after debulking, how will you actually retrieve that broad base out of the scope?
Yeah. So you have to ask the question in a different way. 7 to 8 centimeters tumor is a big tumor, no doubt.
Yes, sir.
Do you think even with a normal TURBT in single stage, will you be able to get a complete resection? That's one of those cases where no matter what, you will do a relook for sure.
Yes, sir.
So it's the same philosophy. You try to debulk the tumor as much as you can. We
Yes,
are now also learning that if you vaporize just the superficial part and you resect the base, because here we just need histology whether there is muscle involvement. So if you map the tumor and do 3 or 4 centimeters in one resection specimen and 3 and 4 centimeters in the second, that you can do it in the same time, but you remove half the tumor, you will find that it's very hemostatic. So you won't have that bleeding that is happening, which we see with typical BT, that you cannot see the remaining tumor in most cases. So that's why the modified ERBT technique, and that's why the EBSAR study is important, because it has also shown that you can get the entire base, you can get a complete resection. It is impossible to get the whole tumor specimen in one block. That's not possible. Now, regarding the tumor seeding, if you have done a complete resection, and because you're using an energy which is actually diathermizing the entire bladder base, once you wash the bladder 15 or 20 times gently with a syringe, which used to be what Professor Studer always advocated as well, you are unlikely to have tumor seeding. That's why the MRI and the studies which I showed you, which showed that there is no tumor seeding happening, there is no recurrence happening up to 3 years. Now, when we say more than 3 centimeters, I didn't go into the very details, but they have gone up to 5 centimeters. And the 5 centimeters is the specimen that's been sent to the histology lab. Whether it was a 7 centimeter tumor made into 2 specimens, no, that we don't know. But in typical practice, yes, it is extremely hard to do. It is not your first case that you should do. You must have a good practice. But with the laser, it's much easier to do it even with the monopolar or bipolar, only because the lasers are more hemostatic and much cleaner. Yeah.
So after doing the entire base with the laser, do you keep some part attached for it to be able to resect it to retrieve the specimen? Suppose if it's a 7 centimeter base, you want to make it into 2 or 3 pieces. Would you like to keep it attached at some part of the bladder, or after resecting completely, you would like
On
to
a practical, it's like, think of it like a very, how do I explain? Think of it like you have a carpet of tumor. Now, when I look at it and I do my cystoscopy and I realize, okay, this is really, really a big tumor, I will first start with the imaginary line which divides the tumor into 4 quadrants in my mind. Then I will start approaching it with the lower quadrant and the distal quadrant of the lower part. So if I take a watch and the tumor is extending, let's say from 1 o'clock till say 6 o'clock, that's a big tumor. Then I will start with the 6 o'clock till 4 o'clock as one piece of the tumor. I will then go from 4 o'clock to 2 o'clock as the next piece of the tumor, and then the last part will be my 1 o'clock. That's how I would approach any really big tumors. With that, I must say that the 7-8 centimeter tumors is not something which I have done too many. I have probably just done 2 or 3. But 3 centimeters, we have done a lot. So at least on that, I'm confident. The 7-8 centimeters, my hospital now, there is another surgeon who's looking after bladder tumor. I do less of oncology work. So generally, we refer such complex cases to them. They are still old school. They still do TURBT. They are not yet moving on to ERBT, but I think eventually, world over, in good centers, they are doing ERBT for even the really big tumors in this way that you have mentioned. Yeah.
What is the size of the resector scope that you use, sir, for a 3 centimeter tumor?
Oh, since we're using a laser, it's the same 24. There's no difference in that here. There's no special difference.
And
I have
you're
tried
using
it with the mini scope, but I heard there's a friend of mine who's doing even ERBT with the MyLab scope. He's able to do it with that as well.
So, are you doing only with thulium fiber laser or
No, no,
in
no.
your center?
We have all the lasers, so we don't. I find the TFL laser to be the most hemostatic, or the Moses. The Moses fiber is extremely expensive, so sometimes I prefer to use the TFL for that. So now it's almost TFL. The 2-YAG laser also works very well.
So is it the TFL 60 watt or is it the 35 watt laser, sir?
We have a 60-watt laser, yeah.
So with that
But I
TFL,
don't think 1 joule 10 hertz is the setting, irrespective of the wattage of the laser which I use.
so if you find any parasitic vessels running around the bladder tumor, so do you use the hemostasis mode initially and then switch over to the incision mode, or you straight away start with the incision mode and 10-1 settings and
It's a good point. So if I find parasitic vessels, I shift to the NBI mode first. If it is just feeders which are superficial, I actually proceed with the resection, and then I diatomize the borders. But parasitic vessels is the one time where you're always concerned whether they're CIS. So you must be a little more careful with that.
So do you change the settings for the hemostasis or
No,
and
it's same setting. Same setting. So 1 joule 10 hertz if it's TFL, 1 joule 50 hertz if it is Moses. If it is TFL 10 hertz, if I want to make it a little more hemostatic, I go probably 5, 4, 5, about 15 hertz. That's all, but not more than that. You really don't have to go more than that.
you do not switch from incision mode to hemostasis mode? You use only the incision mode, sir?
Yeah, we are using we're using the incision mode. Correct. Yeah.
Okay, because we have been using the hemostasis mode initially for the parasitic vessels. We use a 30 watt setting, like 150 hertz and 0.2 joules. And then once all the vessels are coagulated, then we switch over to the incision mode, and for the 10 hertz and 1 joule settings, we switch on. This is what we do.
So what you're talking, this concept is better off when it's upper tract tumor. Where upper tract tumors, you need to vaporize the tumor or hemostase the tumor, then maybe yes. But because it's more of a vaporizing mode, it's actually not a hemostatic mode. But if you do the resection, and you must have done a few, or you must have done quite a few, you'll realize that there is a millimeter of white line that appears, and that is generally the hemostasis. That's because they're all microcapillaries; they all get sealed up.
And for the beginners, when we start actually doing the ERBTs for around less than 3 centimeter tumor, sometimes when we start from the 6 o'clock position, as we approach superiorly, the tumor starts floating and the vision gets obscured, and we don't know actually from which part of the deeper part, how to come superficial. And sometimes the tumor obscures the view, so we are not able to go around the tumor. So what are your tips for overcoming
So
those
So I
difficulties?
think before you start using the lasers, because laser is one thing which you have to go from front to back. It's a little bit difficult to start uh, marking the tumor sometimes behind it. So in those cases, I still think a loop would be a good option, but use the loop in small bursts. So mark that line well beyond the tumor, behind the tumor, when you start off with the ERBT. Because as you're going and by chance, you're not sure, it's like joining the dots. You know, from this line of demarcation where I marked to the second line at the back, once you join that line, you know you've reached your distal extent. If you by chance still get lost, there is still no harm. You can just cut the tumor with the loop, let the tumor float, you can then still continue to do your ERBT to the base. So you send the base separately as a specimen and your superficial tumor as a specimen, just in case you lose it. Preferably, if you can send it in one stock, one base, it's great, but sometimes there's not. That was the main limitation of ERBT until we realized that modified ERBT is actually as good as ERBT. Yeah. So now I'm not too worried if I get two specimens or I have to make it two specimens, put it that way.
So do you think, sir, the area of resection is much wider compared to the conventional TURBT?
I
Because
think so.
when we are going around with the laser in a half distended bladder, it tends to spread and the area of resection becomes wider than we actually wanted to do.
There is a little bit of lateral dissemination of energy, yes, but it's not significantly wider. So it's not like you wanted 5 millimeters and you go 3 centimeters. No, it's 5 millimeters, you may go 1 centimeter, not more than that.
Have you encountered perforations during ERBTs and
No, not with ERBT. I have I don't want to jinx myself, but no. Even once there was a tumor which is sitting at the orifice, and there was another tumor which is sitting in the lateral wall, where this patient, you kind of were sure that it will get a bladder jerk, but we could not give him GA, so we had to do it under spinal, and it was a short spinal, so they said you have to get under. Yeah, even in that patient we didn't have a jerk. There was no perforation at all. Yeah.
And for anterior bladder neck tumors, which are not approachable even with the Creed's maneuver or any suprapubic pressure or anything, it's a fixed part.
Yeah,
How to approach it?
you need a loop. You need a loop.
We need a loop.
Those we don't have a bendable laser still at this point of time, which is why I showed you the pig model that they're developing, the special resectoscope. Now in that resectoscope, there is a flexible tip which can go up, and that flexible is just like a fans. Imagine the fans goes, and it will actually look at that part of the tumor. There's a grasper there, you can actually hold on to it, and then you can get it. So, but that's still under a bit of experimental study. Yeah.
So for all the bladder tumors which you do ERBT, your settings are fixed at like 10 hertz and 1 joule. You've never tried 1.5, 20 or any other combinations.
I've never had to change, really. I've never had to change. I actually discussed with Dimitri Anikev on laser settings, because he has some of the best experience with lasers and tumors. When I discussed with him, and there was no real need to change the settings, so I just follow most of his principles. And I also learned it from somebody, so I don't change too much.
So with the fact that the chances of reimplantation tumor seedling is low and the tumor recurrence is low because of the complete resection, do you think in future the role of mitomycin will come down?
I think single dose mitomycin, perhaps, unless we have level 1 evidence where we compare those who don't get it and who get it. But I don't think single dose mitomycin is really the challenge over here. But we know with evidence that BCG recurrence is much lesser, and even those who don't get BCG, the recurrence is lesser. So I think the need for BCG will definitely come down. I think so, but we need more level 1 evidence on this, which is why all those ERBT registry is looking at.
So as I was quoting previously, the situation where we have planned a resection of 5 mm and it has become larger because of the distended bladder, and the resection, the lateral spread has happened. And sometimes if we see the detrusor muscle and also the fat, do you still give mitomycin postoperatively, or you reserve in certain cases where the resection has gone deeper than you expected?
Unless I'm 100% certain. So if you've done enough BTs, you will realize that there is a difference in the fat, which is perforated fat. That yellow is different from that which is lying in the detrusor muscle. If I have really gone, first thing to do is empty the bladder. When you empty the bladder, when you go back inside, you can assess whether you've really, really gone all out. If you are 100% sure you have perforated, then you shouldn't be given. Then don't give it, it's better.
And how many days do you keep the catheter postoperative, sir, in your experience?
Now, that's what I was saying with the laser ERBT. I try not to give it for more than 2-3 hours now. So I give them the mitomycin, even if it's on table, fine. But in our hospital, we sometimes bring them to the ward and we give them a dose of mitomycin. And we actually then take off the catheter after 2-3 hours. The patient is able to pass urine going well. Find most patients actually tolerating ERBT better, even symptomatically and tolerance. So catheter is not kept overnight in 90% of our patients now.
And do you add any bladder relaxants, anticholinergics postoperatively, even after catheter
Yeah,
removal?
I haven't, we haven't looked at studies to say that it's not needed, but again, we give the patient mirabackground and we tell the patient that if you want and you feel that there is a bit of pain or discomfort, you take it. But honestly, don't have the information to tell you whether how many patients took it and didn't take it for how long. But I don't think with mirabackground now, you're not too worried, or with tolterodine also, it's generally well tolerated, so it's okay.
So if the initial ERBT comes as T1 high grade, you've done the laser resection and you're sure that it is a complete resection and with an adequate depth. If it is T1 high grade, G3, so do you still do re-TURBT?
You should, right? You should. I mean, that is not so. Oncological principles don't change for bladder cancer management. Once you have that kind of, you have to go back. Unless we have, even if it is MRI negative, but there is evidence in that, then you don't compromise on the principles. You go back, relook once again to make sure. Yeah. Yeah. That's unless the studies which are coming up say, yes, you don't have to go back. Yeah.
Okay, sir. Are there any questions, Santosh?
No.
Okay, sir. So thank you so much for patiently answering all our questions.
No, thank you,
Thank
Soundarya.
you for
Thank
the
you for
nice
the time.
discussion and so
Sure.
much knowledge you've inferred to us. Thank
No,
you so
thank you
much,
very
sir.
much. All right. Have a good week ahead. Thanks. Thank you
Thank
to
you, sir.
viewers
Thank
as
you
well.
for the
Bye-bye.
opportunity to host you, sir. Thank you, sir.
Bye. Bye.